Hello, my name is Lynn Walker, and I'm a professor of pediatrics at Vanderbilt University Medical Center, where I served for 2 decades as director of adolescent and young adult health. I've devoted my career to clinical research and treatment of functional abdominal pain. And today, I'd like to share with you some exciting new results of our research. Functional abdominal pain, that's pain without identifiable organic disease, can be extremely debilitating. It derails many children from school and other activities for months or even years, and a significant number go on to suffer chronic pain as adults. There's no standard treatment. The good news is that psychological therapies are promising, but evidence from clinical trials is mixed, and these therapies are not available to the vast majority of patients. In my research, I've focused on advancing our understanding of psychological factors and family factors in functional abdominal pain, with the ultimate goal of improving the effectiveness and accessibility of treatment. Our new study, funded by the NIH, is a randomized clinical trial of cognitive behavior therapy for adolescents with functional abdominal pain. The trial is unique in that we tested the hypothesis that the effects of CBT differ by patient subgroup. Here I want to give a shout out to Amanda Stone and Gloria Hahn, terrific former graduate students who made huge contributions to this work. Before I tell you more about the study, I'd like to give you some context as background because the trial built directly on our previous research. Years ago, we asked the question, can patients with functional abdominal pain be classified into subgroups based on their pain-related characteristics? We recruited more than 800 new patients from our pediatric gastroenterology clinic, and we assessed abdominal pain and other GI symptoms, pain-related cognitions, affect, and behavior. We discovered an amazing amount of heterogeneity and were able to identify 3 distinct subgroups. 2 of these subgroups had high levels of abdominal pain, but they differed on measures of adaptive coping, such as pain catastrophizing and functional disability. We labeled these groups high pain dysfunctional and high pain adaptive. A third group had low pain and was coping pretty well. We labeled it low pain adaptive. We followed these patients for an average of 10 years. We tested the hypothesis that childhood subgroup would predict health outcomes in adolescence and young adulthood. We found that patients in the high pain dysfunctional subgroup compared to those in the other 2 subgroups had significantly worse health outcomes, including chronic pain, disability, anxiety disorders, even job loss in adulthood. I was frankly amazed that patient subgroup was such a powerful predictor of the natural course of illness over years. And what was especially amazing was that we had identified a subgroup of youth who were at high risk for a lifetime of suffering. So that led to our next question, which was, can we apply psychological therapies in childhood that benefit these children as youth? So our current study, published in Pain, tests the hypothesis that the results of CBT differ by patient subgroup. We recruited 300 new patients and randomly assigned them to 2 interventions: internet-delivered cognitive behavior therapy and internet-delivered pain education. CBT was Tanya Palermo's web map, which included skills training for patients and parents with online feedback from health coaches. The other intervention was internet-delivered pain education, which consisted of pain information from reputable websites. A critical and novel aspect of this trial was that we stratified randomization by subgroup. Within each subgroup, patients were randomly assigned either to CBT or education. A primary measure of outcome was gastrointestinal or GI symptoms. I'm really excited about the results of this study because they have important implications that could greatly improve our treatment of functional abdominal pain. We found that among patients in the high pain dysfunctional subgroup, those who received CBT had significantly greater reductions in GI symptoms compared to those who received education. In contrast, in the other two subgroups, high pain adaptive and low pain adaptive, patients received equal benefit from CBT and education. It didn't matter which treatment they got. Now, if we had lumped all of the patients together, we would have missed this critical finding, because when we looked at the total sample, CBT was no better than education. We wouldn't have known that CBT was in fact superior to education for 40% of the sample, those patients in the high pain dysfunctional subgroup. These results suggest that we should prioritize CBT for those patients. And because we've shown that CBT can be delivered effectively through the internet, this treatment could be widely accessible. You'll find more details about the study in our paper. I hope you'll take a look. Thank you.